Welcome to the Explainer. Today, we're basically putting on our medical detective hats to investigate a truly frustrating, silent killer in the dental world, vertical root fractures. We'll be breaking down the current status, the hidden warning signs you need to watch out for, and where we're heading in managing this really complex issue in root-filled teeth. Let's get right into it. So, let's kick things off with a mystery that has baffled and, honestly, frustrated dentists everywhere. Picture this. You've performed what looks like a perfectly executed root canal. The anatomy looks great. The patient, out of pain. Everything seems completely stable. And then, inexplicably, the tooth completely fails years down the road. Why exactly does this happen?
Well, the prime suspect in our investigation is the vertical root fracture, or VRF for short. This is a super stealthy complication. It essentially hides in the shadows, slowly progressing without giving us any obvious clinical signs or symptoms until it's just too late. To be specific, we're talking about a longitudinal fracture that involves the cementum, the dentine, and the root canal system itself.
To really wrap our heads around the massive scale of this problem, just take a look at this staggering statistic. In a retrospective study of extracted teeth that were diagnosed with vertical root fractures, a whopping 93.6% had previously been root-filled. I mean, wow. This prevalence tells us something absolutely vital. The very treatments we use to try and save a tooth are intrinsically altering its biomechanics, making it a prime target for this silent culprit.
All right, moving on to our first major area of focus, the suspects. What exactly is causing these vertical fractures?
Our suspects divide pretty neatly into two distinct camps. On one side, we have predisposing risks. These are factors largely out of our control. Think things like the patient's age or the natural anatomy of the tooth. But on the flip side, we have contributory risks. And these? Well, these are the iatrogenic factors, meaning they're the risks that we, as clinicians, actually introduce during the endodontic and restorative treatment process.
Let's zoom in on those predisposing factors first. Older patients, specifically those over 40, are naturally at a much higher risk, simply due to an age-related decrease in dentinal fracture toughness. On top of that, high-stress posterior teeth, like maxillary premolars and mandibular molars, often have some really complex anatomy. We're talking isthmi, or narrow, flattened roots. These anatomical quirks create natural planes of weakness. Combine all of that with the dehydration of dentine that naturally follows pulp removal. Yeah, you've basically got a perfect storm for a fracture.
But the plot definitely thickens when we look at the contributory factors, the stuff we actually do control. Stripping away crucial pericervical dentine, that critical zone of tooth structure right above and below the crustal bone, severely weakens the root. Add in some aggressive root canal shaping with heavily tapered files, maybe prolonged exposure to dentine-weakening irrigants like hypochlorite, or drilling super wide post spaces for rigid cast posts, and we aren't just leaving the door open, we're essentially rolling out the red carpet for a vertical root fracture. Let's shift gears to section 2, the modus operandi. Let's really break down the anatomy of how a fracture actually happens. The timeline of a tooth's demise generally happens in 3 distinct steps. First step, crack initiation. This starts with a tiny microscopic defect right at areas of high stress concentration. Second, we get fracture propagation. As the patient chews day in and day out, cyclical fatigue pushes that crack further and further through the weakened, dehydrated dentine. And finally, separation. The root completely splits in two, which throws wide open the floodgates for a massive microbial biofilm to just invade the surrounding periodontum.
So the absolutely crucial takeaway here is that we are not talking about an acute trauma from a sudden impact. You're not dealing with a sudden, clean break. Instead, this is a dynamic fatigue failure. It's driven by everyday chewing and parafunctional habits, like heavy bruxism or clenching, just relentlessly grinding away at a dehydrated, structurally compromised root. And this happens over months or even decades.
On to section 3, gathering clues. This is where we run into our biggest diagnostic challenge. You see, gathering clues is incredibly tricky because early-stage symptoms are virtually non-existent. In fact, presentation is often delayed for a good 2 to 5 years post-treatment. But if you play the diligent detective, you might spot a true pathognomonic sign, a very deep, isolated, and incredibly narrow periodontal pocket right on one side of the root. This is totally different from the broad bone loss you'd see in general periodontal disease. You might also notice sinus tracts popping up unusually high, right near the midroot or even the gingival margin.
Now take a look at this visible smoking gun. Clinically, you can clearly see a localized abscess, along with the actual physical separation of that mesial root. It's totally split. And when you match that with a radiograph, it beautifully maps out the dark radiolucency hugging that fractured root segment. That right there is what complete separation looks like in the clinic. But here's the catch. You won't always have such clear, undeniable proof staring you in the face. Standard 2D X-rays are actually notoriously unreliable in the early stages. Why? Because the dense cortical bone plates are usually still intact, and they create what we call anatomical noise. This noise acts like a smoke screen, completely masking the subtle bone demineralization that's happening right underneath. And that brings us to the great imaging debate. We already know standard periapical radiographs totally miss that subtle bone loss. So naturally, we turn to 3D CBCT scans, right? Well, while a CBCT does eliminate that anatomical noise and lets us view the tooth from multiple planes, it definitely has its own flaws. High-density materials in the tooth, like gutta percha or metal cast posts, create beam-hardening artifacts. These are basically streaks of digital noise that can easily mimic the appearance of a fracture, which leads to super frustrating false positives. Which leads us to this golden takeaway from the research. Because of those pesky beam-hardening artifacts, you actually shouldn't use a CBCT to hunt for the microscopic crack itself. You're probably not going to see it. Instead, use the 3D scan to spot the telltale secondary signs. Specifically, keep your eyes peeled for the classic J-shaped or halo pattern of bone loss that typically surrounds our invisible culprit. All right, Section 4, the verdict. Let's talk about what we actually do about this, covering treatment and prevention strategies. Sadly, we've got to face a pretty harsh reality here. For the vast majority of teeth diagnosed with a vertical root fracture, the damage is unfortunately completely terminal. Because we just can't predictably stop the microbial ingress along that fracture line, extraction remains the absolute most predictable treatment of choice. Sure, heroic efforts like root resection or amputation can occasionally be attempted in multi-rooted teeth, but honestly, the overall prognosis is still incredibly poor. Because the treatment outlook is so grim, our ultimate focus as clinicians absolutely must be on proactive prevention. What does that look like? It means meticulously preserving that crucial pericervical dentine during your initial access. It means using conservative, flexible shaping files so you avoid stripping the root walls. It requires swapping out those aggressive wedge and cast posts for passive fiber posts. And crucially, this is a big one, it involves identifying and managing heavy clenching and parafunctional habits with occlusal splints before they fatigue the root to its breaking point. Now, take a look at this number, 4 months. This represents a really critical timeline for your patients. Research actually shows that root-filled teeth that are restored with protective cuspal coverage crowns more than 4 months after endodontic treatment, they are nearly 3 times more likely to be extracted. Delaying that final restoration literally leaves the weakened tooth incredibly vulnerable to everyday occlusal forces. The authors of our source material wrap things up with a vital reminder. Saving the tooth isn't just about cleaning and shaping the canals to perfection. It's about a fully holistic approach. You need to identify susceptible, high-risk teeth right off the bat, utilize conservative structural preparation, and above all else, get that protective crown placed expediently. So, as we wrap up our investigation today, I want to leave you with a bit of a provocative thought. Knowing exactly how stealthy, dynamic, and ultimately destructive vertical root fractures really are, how are you going to change your daily practice? What specific steps will you take tomorrow morning to preserve that vital tooth structure and protect your next patient from this silent tooth killer? Keep learning, keep evolving your techniques, and thanks so much for joining me on this explainer. Chat you next time.